Well, let me introduce myself for the people who doesn't know me. I'm Dr. Dalia Schejtman. I am a medical cardiologist and master in health policies coming from Argentina. And I'm very pleased to be here and very grateful to the authorities of this conference, especially to Dr. McArdle, to let me share my experience leading a multidisciplinary team in Argentina devoted to the health of the police people. We did a special program mostly related with the cardiovascular risk factor of the police, and the data I will show you is the one I'm allowed to display by the National Ministry of Security. And it was this data also was the base of my master thesis in health policies. And this work will be published by the Pan American Health Organization, and it's a branch of the World Health Organization, I think the first semester of 2018. And at least, excuse me for my English, I will try to do my best. And first of all, I want to share some information about my country, Argentina. This is the section of my presentation. Argentina is a large country. It's situated at the south of the Americas region, with a population of 43 million people. Most of them live in urban areas, and it's in the group of upper and middle income countries. Related to the people that made it up, Argentina, it's an immigrant country. It's a melting pot. We say in Spanish, crisol de razas. It received the second biggest wave of immigration in the 19th and 20th centuries. Most of the people came from European countries, mainly from Spain and Italy. And it is said that 70% of the people in Argentina have some Italian genes. That's very funny. You can see this on our streets and in the way we drive. It's a crazy, crazy situation. And there is a lot of other diverse groups living in Argentina. Well, Argentina, it's a nice country with different kind of landscapes. There is fertile and plain areas in the Pampas, a rainforest. In the south of the country's mountains and lakes in the Patagonia region. And there is glaciers in the south of the country. And the Iguazu Falls at the northeast of the country. This is some landscapes of Buenos Aires city. It's our federal district. This is the Puerto Madero neighborhood. This is the 9 de Julio Avenue. It's a wide avenue with an obelisk similar to the Washington, but smaller than the Washington one. This is the La Boca neighborhood. It's very colored. It's where lives most of the immigrants at the beginning. And our famous tango dance. Where we are proud of our Nobel laureates. Argentina is the leading country in Latin America with 5 Nobel laureates. And nowadays, our international famous people, the soccer players, you see, Maradona and Messi, I think you know them. And the Queen of Netherlands, Maxima, is Argentinian. And of course, the Pope Francis. Well, related to the cardiovascular risk factor, they are responsible for the most of the mortality in the world, the premature death, and disabilities. And there is a transition, an epidemiologic transition from the infectious disease to the cardiovascular disease in the world. And this transition is mainly due to the population aging, the rapid urbanization, the dietary changes from more traditional to more processed food, the higher prevalence of physical inactivity, the tobacco consumption, and the harmful use of alcohol. This graphic shows the changes along the years in the pyramid shape, the population pyramid shape, due to the increase of the older people groups. And this is a challenge for the health systems because of the higher cost to take care of the older people. Well, let's talk about the non-communicable disease and the global burden of non-communicable disease. They are responsible for the main proportion of premature death below the age of 70. And between them, the first cause is the cardiovascular disease. The second one is malignant neoplasm. The third is diabetes mellitus, chronic respiratory disease, and other NCDs. And the other part of the premature deaths come from communicable or infectious disease, maternal and perinatal and nutrition conditions, and injuries. Let's see the regional burden of the NCDs. They are responsible They are responsible for almost 5 million deaths a year, the NCDs. 80% of all the deaths are caused by NCDs, and 35% are premature deaths. For the all total groups age for premature deaths, cardiovascular disease are at the top. This is the premature mortality inside the Americas region. This is the southern cone mortality, and this is the North America mortality, a little bit less. And sadly, the Americas region, occupy the first place in the ranking in the world for several of the cardiovascular risk factors. You will see it's in the first place for insufficient physical activity, overweight and obesity, in the second place for heavy drinking of alcohol and high cholesterol in blood, in the third place for high glycemia, and the fourth place for tobacco smoking, and in the sixth place for high blood pressure. And there is an underlying health situation because you can see, you can see only the tip part of the situation, like in an iceberg shape, that is the heart attack and strokes. But most of the problems stay unrecognized, that is the cardiovascular risk factor. And this is our opportunity to prevention. Well, what is the economic burden of NCD? Let's talk about the loss number. In a low and median income countries, the losses are about 4% of the GDP. And if we see the cost by one person per year, the costs are $25 in low-income countries, $50 in low-medium-income countries, and $139 in upper-medium-income countries. And this certainly not only affects the wealth and health of the people, if not but also the development of the country. And how much cost the prevention of this kind of diseases? if we apply the best buy interventions recommended by the World Health Organization, the cost again depends on the type of income country, but it's less than $1, $1.5, and $3 per capita, and has a percentage of the health expenditure is 4, 2, and less than 1%. And remember this number, 1, 1.5, and 3%, and $3 per capita, and again the losses to compare, 25, 50, and 139. It's ridiculous. Well, this is the curve or the natural evolution of the cardiovascular risk along the long life. The yellow part is the natural history, because the cardiovascular risk increases during the years because of the age, the genetic factor, etc. But the orange part is the accumulated individual risk that depends mainly on the behavioral habits. You will see from fetal life through the infancy and childhood, adolescent, and adult life, it increasing. And this is the range of individual risk that we must face. This is the curve of the cardiovascular mortality in the world that descends over the decades, but it descends mainly due to the scientific advances, not for the changes in the behavioral habits. And this is yellow star, I put it here, because it's an Argentinian cardiac surgeon, Dr. René Favaloro. He was a surgeon that performed for the first time the coronary artery bypass graft here in the United States, in the Cleveland Clinic in Ohio, and later he came to Argentina. Well, let's talk about the police health as part of the security policies. The ideas that should guide our steps are: the police health is important not only to themselves, but also to the public they serve. The fit for duty concept, I think, is very, very important, and the health disparity related to the police occupation compared with other occupations is an occupational higher risk problem. And in Argentina, the society is concerned about the situation of the health of the police, and sometimes they appear on the press. This is an article saying, I will translate, policemen with low movement, 8 out of 10 have weight problems. And this problem is only in Argentina, when this is in other countries, it's the same. This is from Mexico Press. You will see problema gordo. It means gordo is fat, but the title means it's a big problem. And see, 100% of the policemen in Mexico have weight problem. Let's see in the United States. This is a picture I took from an article from the New York Times. It's from 1938, showing the FBI agents training in the roof of the Department of Justice building. And nowadays, the article says they return to training in the upper parks in Washington. And it's important. It says that the first director of the FBI, Edgar Hoover, was obsessed about his agents' weight. Well, there are several papers published talking about the health of the police people. And most of them have the same findings. The high prevalence of cardiovascular disease risk factor, higher than in general population. the progressive increase with age, the direct relationship with overweight and obesity, and the protective effect of exercise, healthy diet, and weight loss. What happened in the United States? I was aware reading the paper from Professor Violanti's group from the Buffalo University here in the United States, saying that the life expectancy of the police people is 10 years less than the general population. I said, wow, there is a big problem with this. It was an inspiration for me. Yesterday, I met Professor Violanti here and talked with him and showing my work because really it's an honor for me. Then, as a summary, the police had, if we confirm that they have a higher prevalence of cardiovascular disease risk factor and higher prevalence of other diseases, then they are more prone to having disabilities and premature death. With this picture, they need help. Well, from now on, I will share with you our experience in the Argentine Federal Police personnel. We designed a special program called Programa Salud Segura in Spanish. That's its Safe Health Program. It was for the Argentine Federal Police personnel, the operational personnel. It was a proactive exam, health exam at the workplace of the different stations in the police. And the data collected between December 2011 to March 2015. These are the data that I will show you. Don't be afraid. This is the flow chart of the people. This is the total payroll, but I consider a 30% of missed case because of medical leave or vacation, etc. And this is the number, 11,672 people. And we performed the first screening and intervention in the workplaces. And after 2.5 years as an average, we performed a second health exam in a subgroup of the same people. And we compared the changes in the percentage of cardiovascular risk factors. And we consider this a surrogate or intermediate outcome, because in cardiovascular disease, the final outcomes like major cardiovascular events and mortality, it will take longer periods of time to be measured than maybe decades. So we consider this our result, our outcome. Well, the population gender was, most of them were male and 14% women. And average of age is 35, it's very young people. And this is where the data comes from, the police stations, special forces stations, firefighters, and 911 emergency central. We assemble a kind of circuit in each of the workplaces of the police. The first step was the operator for the data entry station to complete the personal data and history, the health history and family history. And the second station was the nurse to measure the weight, the height, the blood pressure, and the glycemia and cholesterol in blood with the reactive stripe. And they calculate the BMI. The next was the ophthalmology station to measure the visual acuity. The next was the dentist for an oral exam and counseling. The next was the dietitian to personalize counseling and education. And a doctor closed the circuit, a medical doctor, with personalized feedback and counseling, and gave specific educational brochures. And the doctor refers to medical follow-up to the people that will need it. I don't want to see the numbers in this chart. This is the result. But I want to remark two different things. In the blue part of the graphic, you see the police result. It was a direct health exam. And we compare our results with the National Survey for Cardiovascular Risk Factor in Argentina from 2009. But it was a self-administered questionnaire. It was a direct exam. And we choose the two ages group near the average of the age of the police people. The 25 to 34 years and 35 to 49 years. And we will see the results in the next one. All the cardiovascular risk factors are higher. In the blue columns is the police people, and in the red columns, the general population. You will see tobacco smokers, diabetes, with the exception of high blood pressure, I will tell you something about it, overweight and obesity, and high cholesterol. I think that this data is a methodological bias, because if you ask any people at any time, do you any time say that you have high pressure? Maybe the people answer yes. But this is not an accurate data, has the direct measurement. And related to the gender difference, women are in better health condition than men. The red are women and the blue one are the men. And with the exception of tobacco smoking, that is almost the same. And this shows in the same person how many cardiovascular risks stay in the same person. And the important for me is that only a quarter of the people has non-cardiovascular risk factor, you see? And this is very shocking. This is an obesity curve. In red, the general population, a long life. And this is in blue, the police obesity curve. And you will see that for all the ages group, the police people has 2 to 3 times higher obesity rate than the general population. And this is another important thing related to the high systolic blood pressure. You will see that almost 70% of the hypertensive police people didn't know that they were hypertensive. Unknown by person at the time of evaluation, you see? And with the hyperglycemia is almost the same. 62% of the people with hyperglycemia working in the police station didn't know they were diabetics. As a summary, the lack of awareness for hypertensive people was almost 70% and 62% for the hyperglycemia people. And I want to stress something. There is no low-income people without health coverage. They have health coverage from the work, the social security from work. But this is the health situation. Well, this is the group. The second group is a subgroup of the same people in which we performed the second health exam. It was 5 people with similar composition, and the time of follow-up as an average was 2.5 years. Well, the mean of the glycemia descends from the first evaluation to the second one, and has a percentage also, it descends, oh my God, it descends from the first evaluation to the second one. And this is interesting. If you look inside the people with hyperglycemia in the first evaluation and follow up this group, we'll see 74% of the hyperglycemia normalize their glycemia in the second evaluation. And the other people remain the same. And if you dig inside the people with normal glycemia in the first evaluation, some of them became hyperglycemic in the second one. Well, the blood pressure descends but a little bit, has a mean of the blood pressure, but has a group, it descends from the first evaluation to the second one. And again, the same kind of analysis. You see, if you look inside the group hypertensive in the first evaluation, 67% normalize their blood pressure. This is very good. And inside the group with normal blood pressure, some of them became hypertensive. The cholesterol increases, has a mean between the first and the second, and has a percentage in the group, is almost the same without significant changes. But again, if we look inside the group with high cholesterol, 40% of them normalize their cholesterol in the second one. And in the group with normal cholesterol, this is the bad news. 22% became high cholesterol. And this is the worst of all, the BMI worsening from the first to the second evaluation. Both women, the red one, and men became worse. And the excess weight, that is that of obesity and overweight, increases from the first to the second due to both overweight and obesity, and the prevalence of tobacco smokers descend from the first one to the second one. Some people quit smoking. And don't be afraid, this is a chart with the summary of the result for the statistical analysis. Had the mean changes, the only significant improvement was the glycemia, and the BMI was the significant worsening. And has a prevalence changes, the improvement was for hyperglycemia, high blood pressure, and tobacco smoker. And the worsening was for excess weight. And this is the summary of the circle graphic I show you. The people with some abnormal finding at the first evaluation, which percentage normalized their finding in the second one? In hyperglycemia, in high blood pressure, in high cholesterol, and in tobacco smokers. And this is the worsening in the excess weight, from this percentage to this one. This is the brochure or booklet. I have some sample if you want to see. Some of them, of course, are in Spanish. And some of them are for general healthy habits, prevention in health, the decalogue for a healthy lifestyle, and for hyperglycemia, for high blood pressure, how to take care of your mouth, for high cholesterol, and healthy eating habits, and tobacco smoking, how to quit to smoke. Well, the final remarks. I think the money is a big issue because money drives policies. There is a huge disparity in the allocation of the resources between the burden of the NCDs, that is 50%, and the resources dedicated to them, it's 1.22%. And at least in low and middle income countries. And in Latin American countries, the funding for NCDs never risen above 1.5%. Most of the money are still dedicated to infectious disease, to maternal and childhood diseases. And this is a graphic showing this disparity. In the blue columns, you will see the burden of the diseases, and in red one, the money allocated to them from donors, but not donors, people who donor money from big organizations like World Bank, World Health Organization, and some NGOs. And you see, this is the NCD's burden, and this is the money. You see? This is maternal and childhood diseases, other several diseases. HIV, you see? I really congratulate these people to have this amount of money for this burden of the disease. We must imitate them, how to have this amount of money. And for tuberculosis and malaria. And it is well known that the return of investment for this kind of diseases and prevention is very huge. This is an information from the World Economic Forum in 2015, saying that the return of investment in this kind of prevention policies is between 90% to 3,700%. And it's important to think about to apply cost-effective health intervention. What is a cost-effective intervention? For the people who don't know this, is how much money is worth to pay for some health intervention. And the measure is DALY's, Disability Adjusted Life Year, or QALY's, Quality Adjusted Life Year. That is, the World Health Organization put the limit. What is a cost-effective intervention? Is 1 GDP per capita per year gain in some country. And I will tell you some very high cost-effective intervention are the vaccines, for example. And some less cost-effective intervention is to use some monoclonal antibodies against some type of cancer, for example. Well, there is no country with money for everything, you see. We call, in Spanish, we have a phrase, it's la frazada corta. It means the short blanket. Maybe the people who know English better. But if you cover the chest, you uncover the feet. If you cover the feet, you uncover the chest. There is no money for everything. Then each society needs to fix the priorities for health and follow this. The best buy intervention are very well defined by the World Health Organization. It is a guide for all of our countries for NCD management, for cardiovascular disease and diabetes, for cancer and for chronic respiratory disease, for tobacco smoking, for the harmful use of alcohol. Oh, sorry. and for the best diet and physical activity. You will find this in the webpage of the World Health Organization. If not, you will write me and I will help you finding or sending the material. And this is for the people who are planning the policies in health. This is a typical cardiovascular risk curve to 10 years ahead in this axis. And in this one is the percentage of the population. The orange curve is the ideal cardiovascular risk factor to the 10 years. And the dotted curve is what is a real population. It's an example in a real population. And it's shifted right. It's shifted right because you will find a higher cardiovascular risk than in an ideal population. And the right tail of this curve is the people with the higher cardiovascular risk. And we need to apply together those kind of strategies. This is the population strategies with general measure for the population, like to ban smoke in the several places, to reduce the salt intake in processed food, to stimulate cycling in the cities, etc. And for the people with the higher cardiovascular risk factor, you need to apply an individualized strategy with medical treatment and follow-up. When we applied both together, there is most cost-effective. And these are two examples of developed countries that apply the prevention and population and individual strategic together, and they decline the curve of cardiovascular death, you see? It's an optimistic, this is in United Kingdom and this is in Finland. Well, another important thing is the behavior and the habits. We are human living and we are in a social network all the time and influence our behavior, our habits, the fashion, the beauty models, the culture, the imitation, etc. And this kind of behavior affects the health. This is a graphic I took from Dr. Christaki's paper showing that in the yellow circles you will see the obese people that is often surrounded by other obese people. And in the green circles, you will see the people with normal weight, often surrounded by other people with normal weight. And there is a huge discussion between physicians that want to change the name of the NCDs to socially transmitted conditions, STCs diseases, to stress the anthropogenic and socially contagious nature of the disease. This is very new. It's from the Lancet medical newspaper from July 2017. Well, this is new too. This is Richard Thaler, the Nobel Prize, recently he won the prize. And I don't know if you know their work. It's very interesting. She works in behavioral economics, saying that the people are very irrational in their decision. But there is a branch of behavioral health that is very, very interesting to apply. They say that it's not as rational as Spock. Let me see. Well, this is my belief. I think in the top part of the funnel, there is the asymptomatic and healthy people, that is most of the people. And in the bottom part is the people who fall sick with NCDs. But what happened with the money? A little part of the money is applied for prevention. education, awareness, screening tests, and the best buy interventions. And the huge part of the money we expend in treatment, in high-cost diagnostic tests, in pharma costs, in invasive treatment costs, and disabilities and out-of-pocket costs. I don't want to be misunderstood. I don't have against the scientific advances and research. I was one of them. I researched as a cardiology in very basic investigation. For example, in autoantibodies for a cross-immunity between the myocardial muscle and the Chagas disease. You see, I think that it's very important to research and the scientific advance, to have the best pharma drugs, etc. But when we need to think as a policies maker, we need to abroad our thinking. I don't know if I understand me in my English, but I think we need the both approach. The prevention, to put money in prevention, and the best treatment for the people who fall sick. In conclusion, the police health is part of the security logistics, I think. The statistics are alarming. The health intervention for cardiovascular risk factor are very cost-effective and simple. It's not a rocket science, you see, to do this kind of policies. And we must learn from behavioral science, designing simple, capable, and affordable approaches, taking into account the social and network behaviors. We know the problem and how to face it, the health risk appraisal and assessment, with education, with awareness, encouraging healthier behaviors, with medical treatment and follow-up, with technology support, with text messages, with email, with technological device. You see, today we can connect the device to measure the glycemia and send to the doctor, to measure your blood pressure and send to the doctor, etc. The contribution of our health program for the police in Buenos Aires, I think, is simple and very affordable program, showing short-time results, because 2.5 years is short time for cardiovascular disease, and the feeling of support for the personnel. They really love the program and appreciate this. And well, as Confucius quote says, if you already know what you have to do and you do not do it, then you are worse than before. And thank you for your patience. I will be glad to stay in contact with the people related with the health of the police. These are my data. And I open to your question. I'll be glad to answer. Yeah.
If I understand you correctly, especially when it comes to issues of high cholesterol and blood pressure, the slides that you showed was that many of them did not know they had high blood pressure, and many of them did not know about high cholesterol. But all of them got medical aid, social security. And you only found it out, sorry, when you started researching them and you subjected them to these interventions. Is my understanding correct?
I don't know if I understand exactly your question. It was related with the alcohol drinking. Someone will translate me because they are. Okay. 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 Thank you very much. It is my support. Well, the problem is I think is the kind of life of the police people, at least in Argentina. They work a lot, several hours in a day with very high stressful. And the system they had at that time, they need to call for an appointment. And maybe the appointment with the doctor is 2 months ahead, 3 months ahead. And they lose the extra hours salary, you see. I don't know if I explain good, but you see, and they don't want. And I don't show this data, but several times, at the beginning, we don't have a doctor in this review of the health. But we need to put a doctor because the things we saw. Several times we need to call an ambulance and send the police to the hospital, to the emergency room, because hyperglycemia crisis, hypertension crisis, etc. The police people, the problem is the system. The system is not thinking to take care of the health of the police, you see? I think this lack of awareness is, and we are aware that people, that you are hypertensive or diabetic or that's pathologies, and sadly we don't have the data what happened in these 2 years and a half. I was sure you will ask me what happened with the people. What did they do? I don't know. But we educate, we give the brochure, we counsel with the nutrition, with the doctor, and say, and I set appointment directly from the police station to some expedited way, you see, with a schedule. But can you believe me, only 50% of the police went to the medical appointment. Yeah.
See, my other question would have been what has changed, but I hear what you're saying, I'm not sure. Because where I come from in South Africa, all the police belong to one medical scheme. And what our medical scheme does is, with all our big events, they will have a stall there, and they will, as you enter, which is voluntary, but they will take your blood pressure, they will check your cholesterol. So there's a much better awareness already taking place with us, although I must admit, even if they tell me I have high blood pressure, it's still my like you say, it's still my choice whether I want to do something about it. Just a comment.
Okay, that's a problem, yes. I think all of us need, it's a self-responsibility about our health, but you need to educate the people before, because it's a silent diseases, you see. Nobody feel nothing about the hypertension, of the high glucose, glycemia, excuse me, it was in Spanish. Some other question? Well, thank you very much for your patience. Thank you.